is more than just hot flashes. And I'm sure everyone is really excited and intrigued to learn about different ways to cope with it, how to handle it, and just understanding what this phase is really like. While we're here, I'd like to introduce our Senior Vice President of Beyond the Bar Foundation, Rick Picardo, who is a dynamic attorney who is Associate General Counsel at Verizon. She currently serves as the Senior Vice President of Beyond the Bar Foundation, as well as the Chair of the AAPI Committee for the State of New Jersey and a Director of the Ronald McDonald House in New York City.
Thank you for that. And I'm really happy to be here. And I'm glad that we are offering this type of resource under Beyond the Bar to our community, our membership. And I think that Dr. Rolwani, you're going to get a lot of questions on this one. So I say you go ahead and get started with what you want to talk about, because I think a lot of people will have questions at the end, including myself. Thank you.
All right, great. Thank you for having me. For the second part in this series, can everyone see my screen?
Yep.
Okay. So today, as we said, we're going to talk about perimenopause. I promise this is the only pun in the whole talk. The inflection point no one briefed you on. I know we have a lot of attorneys on the call. And as we said, it's not just hot flashes. And we are going to talk about hot flashes today. I do think they get dismissed and minimized. So we are going to talk about those as well. But perimenopause is so much more than that. And so I wanted to start to introduce you to everything that it encompasses, especially as we said, now women's health is getting a little bit more attention, well deserved. So we all want to be informed about it. So I have some scenarios here. One is Mary is 48 and her doctor said there's no way she's in menopause, but she wakes up every night at 3 a.m. and can't fall back asleep. Does that sound like anyone on the call? Rena is 46, and today, not only did she forget where she put her keys, when she tried to ask her son for help, she could not remember the word for keys. That may be someone on this call. Barbara is 55 and has been a trial lawyer her whole career and used to thrive on the courtroom, but lately she finds herself very anxious every time she has to appear in court. That may be someone in this room. And Sheila is 52 and a CEO. She feels she can't multitask anymore and has noticed her mind wandering off at inopportune moments like board meetings. So these are all common scenarios, and these can all be part of perimenopause. And these are all scenarios that people don't necessarily think about because they don't have the traditional hot flashes. So as far as tonight, what we're going to cover is what perimenopause is, who it affects, what symptoms are part of it, the main hormones involved, the effects on overall health, possible treatments, and final tips and takeaways. So the disclaimer is the info reviewed tonight is general medical information. You cannot take it as personal medical advice. Also, we are recording this talk. I'm going to post it online for everyone, hopefully by tomorrow. So let's talk about some definitions. So perimenopause is not the same as menopause. It's not the same as postmenopause. So the definition of menopause is going 1 year without a period. That 1 day is menopause. Everything after that is postmenopause. And everything before that is perimenopause, where you're in that transition period. And it can last 5 to 10 years. And we're going to talk about, it's important because what's happening, we used to think that menopausal symptoms were all from lack of hormones. So what's happening, though, is not the lack of hormones that's causing the problem. It's the fluctuation in hormones that's causing the problem. Okay, so it's more like puberty in reverse than a slow decline. And you'll see me coming back to this analogy a lot tonight. I think it's a good explanation that we can all understand. So if you remember puberty, it wasn't like everything did suddenly change at once, but it was a lot of ups and downs for a while. And you may remember it from your kids going through it. And likewise, you're not the same after as you are before, and you can't stay in one spot. Right? So our bodies were not meant to be hormonally static, but we are meant to stay cognitively sharp and metabolically healthy. So these are the main hormones involved. We have estrogen, which, as I said, it doesn't just fall, it fluctuates wildly. We have progesterone, which is the first to drop, and that's often what leads to sleep issues. And then we have the brain. Well, the brain is covering everything. One thing we're finding out is that there are estrogen receptors that are actively readjusting to this new rhythm. And even though a lot of times it's posited as a decline, your brain, they're actually learning, has neuroplasticity in menopause. So it's even more important to keep your brain active and engaged. So I wanted to show this graph because I feel like it illustrates what I'm talking about. So these are hormones in menopause. These are your estradiol levels. And notice they're not zero. You still have some. This is in premenopause. This is a typical cycle. And this is perimenopause. And so you can see here what I mean by hormone chaos versus hormone loss. The other thing I wanted to point out is in perimenopause, your levels can be very high. They can be higher than they were before and after, okay? So that goes back to, it's not just lack of hormones, it's the fluctuation in hormones that's causing the issue, okay?
Dr. Rolwani, I'm so sorry to interrupt you. I think there are a few people waiting in the waiting room to be let in. If you can do that, please.
I only saw one and I let them in.
Okay. Thank you.
Yeah. I hope it's not too jarring when I have to go back and forth between screens. All right. So I wanted to show this picture because it's a recalibration. And there's also been a lot of changes in our attitudes toward this. So the picture on the left, for those of you who may remember the Golden Girls, that was Blanche. And when she started the show, her character was in her 40s. So she's around 50 in this photo here. And then on the right, we have, of course, J-Lo, who's currently 57 and looks like that. Now, for those of us who never looked like that, it's probably not going to happen after menopause. But I wanted to point out that even J-Lo, whose job it is to look like that, has said that it became much harder after menopause. So I do want to talk about this concept of you are not too young. So a lot of people I see tell me their doctors told them they're too young for perimenopause. So the average age of menopause is 51, and most women start to have symptoms 5 to 10 years before that. And in certain situations, even though the average age is 51, certain groups are more susceptible to having it earlier. So it's not unusual to start having symptoms in your 30s. The strongest predictor of when you're going to go through menopause is your mother's age. A history of infertility or hormonal irregularity often means earlier, like if you've done IVF, and then certain ethnic groups go through it earlier, so Asians and South Asians. Okay, symptoms are routinely mistaken for stress or burnout, which often coexists in this same time frame. And I can tell you, I've had a number of women tell me every time they went to the doctor, they were told, oh, it's anxiety. Oh, it's anxiety. And maybe it was, but maybe there was something else going on as well. And your hormones also do affect your anxiety levels, as we'll talk about. So in terms of symptoms, like I said, it rarely shows up as a hot flash first. Hot flashes are common, and honestly, that's kind of easy. You know what that is. And there's some women who have hot flashes long before menopause, just from normal fluctuations in their cycle. But some of the more subtle symptoms are going to be anxiety out of nowhere, 3 a.m. wake-ups, brain fog. Words are harder to retrieve, trouble word finding. Low frustration tolerance. Usually women will say, well, actually, my partner told me that I'm very young. Palpitations in situations where you didn't have palpitations before. This one I really want to mention, heavier periods. Again, people think about their periods disappearing, but the first changes are that drop in progesterone, and it's really common to actually have more frequent periods. So for your cycle to go from 28 to 24 days, that's actually very common. Abdominal weight gain on the same diet. I feel like every day women are telling me I've changed nothing and my weight's around my middle. And then higher cholesterol in labs that were always fine before. The most common sentence of all is going to be, I don't feel like myself. I don't recognize myself anymore. So I wanted to talk now about the 3 hormones that are involved with this, the 3 main ones. So I said progesterone is the first to dip, and that one affects your sleep. So that's usually the first symptom that women will tell me about. They wake up at 3 a.m. and they can't go back to sleep. It is a bit of a mood stabilizer, and it's mainly sleep. And we'll leave it at that. Estrogen is the main hormone that we all know and think about, and we're finding estrogen receptors everywhere. So there are estrogen receptors in the heart, in the blood vessels, in the bones, in the brain, in the gut. It is responsible for most of the vasomotor symptoms, so symptoms like hot flashes and night sweats. And then the third one that doesn't get talked about as much is testosterone. Remember, even as women, we do have both male and female hormones, and we do have a significant amount of testosterone. Testosterone levels do not change in menopause, but they don't have as much estrogen balancing it out. So even if you have the same amount of testosterone, if you have less balancing it out, you're going to feel a difference. So we think of testosterone as responsible for libido, motivation, confidence, drive, and muscle mass. Now, I wanted to give a couple of honorable mentions to a couple of other hormones. One is cortisol, which is all over social media. It's a hormone that we all make. And then thyroid. So in terms of thyroid, I actually joked that I was going to call this talk, "It's Not Your Thyroid," because thyroid often looks like the answer, but usually isn't. And it's the one that we know to ask for as patients. We know that thyroid can cause fatigue and weight gain, but it's much more common for women to have that from perimenopause. The good news with the thyroid is it's pretty easy to check. You just do a blood test. The TSH is a basic screening test. It's done as part of your physical every year. And like I said, a lot of these symptoms do overlap. But because the thyroid testing is so sensitive, you can do the test and rule it out pretty easily as well. I know some celebrities have said you need, more in-depth testing. Usually not. For most people, TSH is enough. So where a lot of women tell me they get stuck is they go see a doctor and they get some labs checked, and the doctor says, your labs are normal, everything's fine. It may be fine, but that still doesn't mean that you feel good, and it doesn't mean that there's nothing that can be done. Again, going back to our puberty analogy, even though that's normal, there are things we can do to mitigate the effects when they become a problem. So as I said before, estrogen was protecting many systems at once. There are estrogen receptors in the heart. So after menopause, heart disease risk accelerates. Bone density will decline. You actually lose the most bone in the last year of your period and the first year after that. And there's some things you can do to mitigate that, which we can talk about. I also just posted a video on Instagram about 5 ways to increase your bone density. So we've already talked about you start to lose muscle mass. Most of us women do not do enough resistance training. This is a really good time to start building weights. And some of these changes are better done, most of them are done in terms of lifestyle right before the period stops. So if you wait till the periods stop, you've already lost bone and muscle, and it's hard to get those back. And then last of all, mood and cognition. So as I've said, the brain is an estrogen sensitive organ. So the most common things I hear are going to be brain fog and mood shifts. There's also a good amount of ADD that comes out around this time. And it's unclear whether these women had ADD to begin with, and the estrogen was helping them compensate for it, or whether this is de novo from the lack of estrogen. But either way, it is a common symptom that I see. So we've mentioned that estrogen affects all these things, and if you go through menopause earlier, then that risk window also opens sooner. So people who are at risk for going through menopause earlier are women who've gone through surgical menopause. So even if you have one or both ovaries, if you've had surgery, then you're at risk for going through menopause earlier. Earlier premature menopause is anyone before the age of 45. And so if you think about it, I saw a woman this week, she went through menopause at 42. So I told you the average age is 51. That's an extra 10 years without estrogen, which is significant to the body. And then ethnicity, as I mentioned, certain ethnic groups tend to go through menopause earlier. So the changes that we typically see physiologically in terms of metabolism are cholesterol goes up, blood pressure goes up, and visceral fat tends to go up. And this is, again, what I was saying, a lot of women will say, all my fat is around my middle. And studies have shown that the number doesn't change in terms of weight, but every woman will tell you there's increased visceral fat. There was actually a really interesting study that came out this year that showed, again, that all these markers went up, blood pressure, cholesterol, and blood sugar. What was interesting about that study is those women actually had lower BMIs and lower waist circumference than the premenopausal women, which suggests that it's not just fat, that there are other changes happening as well that put us at higher risk at this time. And then if you've had any kind of insulin resistance, say through PCOS or gestational diabetes, then that compounds this risk even further. All right. So one thing I want to stress is perimenopause is a clinical diagnosis. As I was saying before, with the thyroid, it's pretty easy. You do a blood test, you figure it out. There is not a single blood test for perimenopause. It's based on your symptoms. Things that are not going to be helpful are checking one random estradiol level or even a single FSH level in early perimenopause. So if you'll remember those graphs I showed you, your numbers can be even higher in perimenopause and you can still feel bad. Salivary hormone panels are not backed by science. So they're useful for cortisol, for looking for too much cortisol, but not really for these hormones. They're not scientifically validated. And then in general, a hormone panel, there's no such thing. So your doctor should be asking you your symptoms and then checking your hormones appropriately. So again, your symptoms and the pattern over time. So it's important to have an ongoing conversation with your doctor. Often using these hormones, again, we're treating your symptoms. So we adjust the doses based on your feedback. And regardless of your symptoms, it's an important time to start checking these metabolic risk markers. So it's kind of the opposite. If you have symptoms, you're going to go by those and not check hormone levels. Even if you don't have symptoms, you are going to check these metabolic risk markers. It looks like someone wants to be let in. Give me a minute. All right. So I wanted to throw this in because people tell me it gets very depressing talking about and hearing about perimenopause, but there are some good things. A lot of women have shared this, and this is actually from a magazine, that they just have lower tolerance for nonsense, and there's a reprioritization that happens in this period. In addition to the hormonal recalibration, there are prefrontal cortex changes that are seen on fMRI. And, you know, part of this is you've just lived your life and you become more clear on your boundaries. You're less concerned about pleasing other people. You have more confidence. And I think, you know, I think back to my 20s, and there's always that one woman who, you know, everyone was like, wow. And hopefully we can all aspire to be that woman. And I think part of that, yes, part of it is wisdom, but part of it is these hormonal and physiological changes. So in terms of treatments, this is the scaffolding. Hormone therapy, there are a whole bunch of options. There's oral, there's transdermal, there's transvaginal, which falls under transdermal. You may need 1, 2, or 3 of the hormones. If you have a uterus, then you do need progesterone in addition to estrogen. The 3 hormones, remember, are estrogen, progesterone, and testosterone. Not all women need all 3. Then muscle, we talked about focusing on strength training and protein intake. In terms of how much protein, it's a little bit controversial. I can talk to you more about that if there are questions, but basically more than you're comfortable with. I think if most of us doubled our protein intake, we would still probably be under what a lot of weight training people use. In terms of sleep, this becomes very important. And I think it's one of those situations where it was always important, but it becomes even more noticeable at this time. Sleep has been tied to changes in metabolism, heart disease, blood pressure, all the things. And it was funny, there was something on social media. This woman was talking about how when she traveled in her 20s, she would sleep on the floor of a hotel room for 2 hours and have 3 saltines and be ready to go. And now when she travels, she needs her sleep mask, her special pillow, her weighted blanket, her sound machine. You know, whatever it takes, you need to protect your sleep. Alcohol, I want to mention this. We used to think 1 to 2 drinks a day was okay. Now we're finding out that pretty much any amount of alcohol is not good for you. It may be unrealistic to stop drinking, but I would at least start cutting down. If you're used to going out on a Friday night and having 4 cocktails, then maybe switch to 2, maybe drink water, maybe drink some mocktails in between, but it's time to start cutting back on alcohol for all of us. And then supplements. I feel like a lot of people will skip the first 4 and go to the supplements, but really the first floor are the walls and the supplements are the roof. So you want to concentrate on the first 4 and then think about supplements. I'm not huge on supplements, but there are some that have evidence behind them. So magnesium is good for helping you relax, so it's good for sleep at night. Creatine actually has some evidence for brain function. And then vitamin D. So for our bones, most women should be on calcium and vitamin D. So another thing I want to talk about with hormone therapy is hormone therapy was kind of a taboo subject for a while. Not many doctors were prescribing it. And then last year, the old black box warnings were taken off. So even if you've been told that hormone therapy was not an option in the past, it's worth revisiting because we're finding out more and more about these hormones and how some of the conclusions that we had before were not correct. In terms of safety, the route matters. So probably the safest route is going to be transdermal. And the reason is when you take them by mouth, what happens is they go through the liver and they can affect the liver. It's called the first pass effect. This term bioidentical is largely a marketing term. Technically, the patch that I prescribe, micronized progesterone, those are considered bioidentical. Those are close to what the body makes. And you want something that you can pick up in your pharmacy. I mean, you're putting something in your body, so you want something that's been tested and regulated. One of my colleagues in residency used to say, snake poison is natural. That doesn't mean it belongs in your body. So just be careful about anything you're putting on or in your body. And then the cautions for hormone replacement therapy are going to be people with a history of blood clot, breast cancer, or cardiovascular disease. Now, there are very few absolutes in terms of this. I have women with all these conditions who are on hormones, and it really depends on the specifics. And like I said, if you've been told you weren't a candidate before, it's probably worth revisiting. Another point I want to make is it seems more and more the timing of starting the hormones matters, meaning starting them within 10 years of when your periods stop. So remember, I was pointing out the difference between if your periods stop at 42 or 52. So that 10 years can make a really big difference. Yeah, admitted a couple more people. They got here just for the last slide, almost the last slide. So some of the final tips and takeaways are that the transition for menopause is temporary. The trajectory is not. It's more than hot flashes. It affects a lot of different organ systems, and to be aware of those. It's diagnosed by symptoms and pattern, not by chasing any specific labs. And you absolutely need to get your metabolic risk markers checked. So most of us know to get our mammogram every year. Women are still 7 times more likely to die of heart disease than breast cancer. Most of us don't know to get these other things checked. Okay, and so I wanted to spend a few minutes and talk about those. So the standard panel was total cholesterol, triglycerides, HDL, and LDL. So as I said, heart disease is still the leading cause of death, even in women. And normal doesn't mean that you're safe. So we all know people who've had heart attacks, even with quote unquote normal cholesterol. So these catch a lot of people, but not everybody. And so this panel is one that's going to give you a lot more information. ApoB, which is particle count, Lp(a), which should be checked once, that's a genetic score, your triglycerides and HDL, which are checked every year, fasting insulin, and a CRP. So these tests are relatively inexpensive. If you have insurance, they're $0 to $30. And they're basic enough that a primary care doctor should be able to check them. Okay? They're not done routinely, but you should be able to ask for these and get them without too much of a problem. As part of my workup, I do more of a preventive cardiology workup, so I am checking additional tests. But like I said, these are fairly easy and accessible, so you should be able to get these. And then I also wanted to take a minute and talk about cholesterol guidelines. So in March, there's some new cholesterol guidelines that were released, and the targets are moving lower. And so I wanted to make that point. When I started practice, the target was 160. If your LDL was more than 160, then that was a problem, and we put you on medicine, regardless. And then it lowered to 130, and now it's 100. So even if you have no risk factors, nothing else, your LDL should be under 100. If you have some risk factors, it should be under 70. And if you have actual heart disease, it should be under 55. Okay. There are certain ethnic groups that are more at risk. South Asians and Filipinos are at very high risk for heart disease. So it's especially important for them to have some of those other tests that I mentioned. Lp(a) should be checked once, and it should be checked in women and in men because that is a measure of your risk of heart disease long term. It's separate from the LDL. Like I said, it's a genetic risk factor, and basically it means when you get a clot, it's more sticky. And then the other thing that was in the guidelines that I wanted to mention is they're actually recommending kids get screened now at ages 9 through 11 to try and catch genetic problems earlier. So in conclusion, in terms of perimenopause, you're not too young, you're not imagining it, and you're not out of option. You need someone who's looking at the whole picture. And that's a little bit of what I do with my practice. So I wanted to talk about that. I have a practice called BC Bill. It's in Atlanta, but I do have telemed licenses in multiple states, including New York and New Jersey. My practice is a concierge practice. And if you're interested, I would love to work with you. I actually want to thank Beyond the Bar for inviting me to speak today. We are going to get to questions. I'll stop the recording for that so that you feel like you can ask them with some privacy. I'm going to post this recording on my YouTube channel. There are additional resources on my website.